Welcome to the deep dive. Today, we are strapping in for, well, arguably the wildest 2 years of early childhood development, the dynamic toddler period. We're talking ages 1 to 3.
Absolutely. It's a huge transition time.
So if you're working through the essential knowledge for pediatric nursing, consider this your roadmap. We're aiming to cut straight to the clinical core,
Right.
giving you what you need to grasp the physical, cognitive, and psychosocial challenges. That whole holding on and letting go stage people talk about.
And that phrase, holding on and letting go, it really captures the central conflict, doesn't it? For nurses, for parents, understanding this phase is just crucial to reducing conflict, frankly.
It sounds like it.
This is Erickson's stage, autonomy versus shame and doubt. And if you don't get that the toddler is fundamentally driven to gain control, pretty much every interaction can turn into a power struggle.
Okay, so how does that drive show up? You mentioned something earlier. The classic no.
Exactly. Their favorite word. It's called negativism. And, it might seem frustrating, but it's actually a really healthy assertion of independence, of self-control.
Huh. Healthy. Okay.
Yeah. And we also need to keep terms like egocentrism in mind. It sounds negative, but it's not about being selfish. It's a developmental stage where they literally can't see things from another person's perspective.
That makes sense.
And knowing that changes how you approach everything,
Yeah.
From explaining a procedure to just offering comfort.
Okay. So let's start with the physical side then, because that incredible growth spurt of infancy, it really slams on the brakes here, doesn't it?
It does, a significant slowdown. You're looking at maybe 3 to 5 pounds gained per year and about 3 inches in height. Usually comes in spurts, not steady.
Right. So parents might worry if they don't see constant growth.
They might, yeah. But the key nursing takeaway, the big marker, is that toddlers generally reach about half their adult height by the time they're 2 years old.
Half their adult height by 2?
Wow, okay. And their whole look changes too, right? They stop looking like round babies.
Totally. You get that classic toddler appearance, the pot belly. That's just because their abdominal muscles are still pretty weak,
Okay.
and they often have that slight sway back posture, plus that very typical wide stance when they walk, kind of uneven. We call it the toddler gait.
Yeah, you can spot it a mile off that I'm still figuring out this balance thing.
Yeah, exactly. And then, looking at the head, growth slows there too. It reaches about 90% of its adult size by age 2.
Okay.
But the really critical piece for assessment is the anterior fontanel, that big soft spot on top.
Right.
It absolutely needs to be closed by 18 months. If you assess a child much older than that and it's still open, well, that's an immediate red flag. Needs investigation for potential neurological issues.
Got it. Fontanel closure by 18 months.
Right.
Okay. So system-wise,
Yeah.
what's maturing inside that lets them, move beyond diapers and baby food? Well, the neurological system is a huge part of it. Myelination, that insulating sheath around the nerves, especially in the spinal cord, is largely complete by 24 months.
And the clinical significance of that is?
It's massive. This myelination allows for much better coordination, improved equilibrium, and crucially, the ability to gain voluntary sphincter control.
Ah, okay. The physical readiness for toilet training.
Precisely. That physiological piece has to be there. You can't really rush it effectively before the body's ready.
Makes sense. What about other systems, like digestion?
Yeah, the GI system matures too. The stomach gets bigger, holds more, which is what allows toddlers to shift to, say, 3 meals a day instead of constant grazing. Stool frequency usually decreases. But, and this is important to tell parents, their intestines are still functionally a bit immature. So it's totally normal to see, like, whole pieces of corn or peas in their diaper. Doesn't mean anything's wrong.
Good to know. Less worry for parents. And what about urinary changes? Kidneys, bladder?
They reach sort of near adult function between 16 and 24 months. The bladder capacity increases too. But here's the nursing alert we really need to stress.
Okay.
The urethra is still quite short in both boys and girls at this age. And that short pathway makes them much more susceptible to urinary tract infections, UTIs, compared to older kids or adults. It's a key vulnerability.
Right, so hygiene is extra important. Okay, so they're mastering walking, running, controlling their bodies physically. That must feed right into the psychological stuff, right? The desire for independence now has legs, literally.
Exactly. You've hit it. We're smack dab in the middle of Erickson's autonomy versus shame and doubt. The physical ability fuels that psychological drive.
And it's not always smooth sailing emotionally?
Oh, definitely not.
Yeah.
You see a lot of what we call emotional ability. Really rapid mood swings. They can go from happy to furious in seconds, often triggered by frustration. Their desires are strong, but their skills, physical or verbal, might not keep up.
Sounds challenging.
Can be. But the nurse's role isn't to shut down that drive for independence. It's to guide it.
So how do we do that, practically speaking?
A key intervention, especially for managing that negativism and heading off power struggles, is offering limited, appropriate choices.
Ah, the choice technique.
Yes. You give them two acceptable options. Do you want the red cup or the blue cup? Do you want to put on your PJs before or after this story? It satisfies that craving for control, but you, the adult, still set the boundaries.
Smart. Okay, and cognitively, what's happening in their little brains?
Big shifts there, too. They're moving out of Piaget's sensorimotor stage, usually around age 2, and entering the preoperational stage.
Preoperational, what does that look like?
It means a huge explosion in symbolic thought. They can start using symbols, words, images to represent things, and they develop delayed imitations. They might see something and then imitate it hours or even days later.
Interesting. You mentioned animism earlier. Where does that fit in?
That's part of this symbolic preoperational thinking. Animism is attributing human feelings or intentions to inanimate objects.
Like if they trip over a toy, the toy is mean.
Exactly. Or in the hospital, maybe the IV pole seems scary, or the blood pressure cuff feels like it's squeezing them because it's angry.
So as nurses, we need to address the object's feelings.
Sometimes, yeah. Acknowledge the child's perception. Let's tell the cuff to be gentle. It validates their thinking, which is rooted in that animism. It can really help reduce fear.
Fascinating. And this ties into their social development, too.
Directly. The big themes socially are separation, realizing they are their own person, distinct from their parents and individuation, forming that unique sense of self.
Which leads back to...
Egocentrism.
Yeah.
That focus on their own perspective. Because they're so busy figuring out who they are, they genuinely can't process that someone else might have a different feeling, need, or viewpoint.
Got it. It's not intentional selfishness, it's developmental.
Precisely. And something else we often see reemerge around 18 to 24 months is separation anxiety.
Oh, right. That can come back.
It definitely can, and it can be quite intense. Major distress when the main caregiver leaves. But the good news is it usually eases up again by around age 3.
Why is that?
Because they achieve something called object constancy. They develop a reliable internal picture of their parent. They know the parent exists and will return, even when they can't see them. That internal representation provides security.
Okay, that makes sense. Let's shift back to physical skills for a moment. Motor development. We talked about the toddler gait. How does that progress?
Well, it's quite a rapid progression, actually. They typically start walking independently somewhere between 12 and 15 months, maybe a bit wobbly at first.
Right.
By 18 months, many are running maybe more like a hurried walk, and they can often kick a ball.
Okay.
And then the coordination really takes off. By 36 months, so age 3, they can usually pedal a tricycle. And a big one is stairs. They can walk up and down stairs using alternate feet, 1 foot per step, instead of that step-together pattern.
That's quite an achievement. What about fine motor skills? Hands and fingers.
Also crucial for their sense of competence and, getting ready for preschool tasks. They move from kind of clumsy grasping to being able to manipulate objects much better.
Like stacking blocks.
Exactly. That's a classic measure.
Yeah.
Maybe stacking 4 cubes around 18 months. By 36 months, they might be able to stack 9 or 10 cubes.
Wow.
And you see progress with utensils moving from just banging the spoon to actually using it somewhat effectively. And really importantly for later skills, developing the ability to hold a crayon or pencil in a proper writing grip, not just a fist grasp.
So much development happening. And then there's language.
Oh, language explodes. But the absolute key thing to remember here is that receptive language, what they understand, vastly outpaces their expressive language, what they can actually say.
So they understand way more than they can tell us.
Way more. Which can be a source of frustration for them, actually. Think about it. You know what you want, but you don't have the words yet.
Yeah, that makes sense. How fast does vocabulary grow?
It's astonishing. From maybe just a few meaningful words at age 1, they typically hit around 50 words by age 2. And then it jumps dramatically, maybe up to 1,000 words by age 3.
1,000 words? That's incredible.
It is. And that's why reading to toddlers, talking to them constantly, is so vital. You're feeding that receptive bank, which fuels the expressive explosion later.
Okay. And we hear some specific types of speech, right? Like echolalia.
Yes, echolalia. That's repeating words or phrases they hear, often without fully understanding the meaning. It's perfectly normal, especially before about 30 months old, with a little parrot face.
Okay. And telegraphic speech.
That comes a bit later, as they start putting words together. It's like sending a telegram that uses only the essential words, usually nouns and verbs, to get the message across.
Like want cookie or doggy go outside.
Exactly. Want cookie milk. Highly efficient communication. One other quick note. For children learning two languages, their first spoken words might seem slightly delayed compared to monolingual kids, but it's not a true delay. They're acquiring both languages simultaneously, which is complex but totally normal.
Good point. Okay, let's pivot to the clinical application. Nursing process.
Yeah.
Given everything we've discussed, the mobility, the curiosity, the lack of judgment, what's the primary nursing diagnosis here?
Unquestionably, it's risk for injury. This has to be top of mind for every nurse working with toddlers or advising families.
They really are little accident magnets, aren't they?
Completely. Their drive to explore is huge, but their ability to sense danger is practically zero. So nursing guidance has to be super specific and urgent.
Okay, give us the highlights. What are the absolute must-dos for safety?
Car seats.
Yeah.
Rear-facing until at least age 2, or until they reach the seat's height-weight limit for rear-facing.
Yeah.
That's non-negotiable.
Right.
Comprehensive child-proofing of the home. That means gates on stairs, outlet covers, securing furniture that could tip, and absolutely locking up firearms safely and separately from ammunition.
Okay.
Kitchen safety. Turning pot handles inward on the stove so they can't be grabbed. And helmets required for any wheeled toys like trikes or scooters.
Got it. What about poisoning? That seems like a huge risk, too.
It is enormous. Toddlers explore with their mouths, and they don't have case discrimination yet. Everything goes in. Nurses must counsel families. Post the Poison Control Center number. It's 800-222-1222. Somewhere obvious, like on the fridge.
Okay, 800-222-1222.
And every single potentially harmful substance medications, cleaning supplies, detergents, even some cosmetics must be stored in their original child-resistant containers, and ideally up high in locked cabinets, not just out of reach. Locked.
And that point about medicine.
Crucial. Never, ever refer to medicine as candy to try and get them to take it. Ever. That association is incredibly dangerous.
Absolutely. Any other major injury risks?
Drowning. Tragically, it's the leading cause of unintentional injury death in this age group.
Wow. Even in small amounts of water.
Yes. People don't always realize it can happen silently and quickly in just inches of water, a bathtub, a toilet bowl, even a bucket left outside.
So constant supervision is key.
Constant, vigilant, touch supervision whenever they're near any water. And know that most kids aren't really physically or cognitively ready for formal swimming lessons until around age 4. Flotation devices are aids, not substitutes for supervision.
Okay. Sobering but essential advice. Let's shift gears a bit. Nutrition. This is often a big source of parental stress, right? The picky eater phase.
Oh yes, very common frustration. And the first thing nurses need to explain is the concept of physiologic anorexia.
Physiologic anorexia sounds serious.
It sounds scary, but it's not. It simply means their appetite decreases because their growth rate has slowed down so dramatically.
Ah, back to the growth slowdown.
Exactly. They genuinely need fewer calories per pound than they did as infants. It's normal for them to eat less overall or be really inconsistent eaters. It's not usually malnutrition.
That must be reassuring for parents to hear.
It is. We also need to guide them on appropriate portion sizes, which are much smaller than adult portions, and on fluid limits.
Limits on fluids. Like milk?
Yes. Too much milk or juice can fill them up and displace nutrient-dense solid foods. The recommendation is usually around 16 to 24 ounces of milk per day, and keep juice to a maximum of 4 to 6 ounces, preferably served with meals, not sipped throughout the day.
Okay. And weaning from the bottle.
Should ideally be completed by 12 to 15 months. Prolonged bottle use, especially at night or nap time, significantly increases the risk for dental cavities. Transitioning to a cup is important.
Makes sense. And choking. Still a big concern.
Huge concern. Their chewing skills are still developing. So food needs to be cut into very small, manageable pieces. No whole grapes, no nuts or seeds. Avoid hard candies, popcorn, chunks of peanut butter, hot dogs, unless cut lengthwise and then into tiny pieces. You have to be really careful.
Okay, safety first, even with food. Now, discipline, another hot topic.
Definitely. And the key perspective shift is that discipline means to teach or to guide, not just to punish.
So how do we guide a toddler driven by autonomy?
It comes down to clear, consistent limits and positive reinforcement for desired behaviors. And understanding their developmental stage, they aren't trying to be difficult. They're trying to assert themselves.
What about physical punishment, like spanking?
Well, we need to be clear about the recommendations. Both the American Academy of Pediatrics, AAP, and the National Association of Pediatric Nurse Practitioners, NAP, strongly advise against corporal punishment.
Why is that? What does the evidence show?
The clinical literature indicates it's generally less effective long-term than positive discipline strategies. It can increase aggression in children, model violence as a way to solve problems, and potentially harm the parent-child relationship. We report that impartially, as per the sources.
Okay. So what are the recommended effective techniques?
We already mentioned offering limited choices.
Yeah.
Another big one is using extinction for certain behaviors.
Extinction.
Basically, systematically ignoring minor, non-dangerous behaviors that are done purely to get attention, like whining or maybe mild tantrums. If the behavior doesn't get the desired reaction, attention, it tends to decrease over time.
Ignoring the behavior, not the child.
Crucially, yes. And role modeling is huge. Parents managing their own frustration calmly teaches the child emotional regulation. For tantrums, which are often from frustration or lack of language,
Yes.
if the child is safe, ignoring the tantrum itself is often best. Trying to intervene or reason during the peak usually escalates it. Distraction before they reach peak meltdown can also work wonders.
Okay. Let's touch on a couple more common developmental hurdles. Toilet teaching. When are they ready?
Readiness is key, not age alone. You look for signs. Can they walk well? Can they pull their pants up and down? Do they stay dry for periods of time, like a couple hours? Do they show awareness, like telling you they need to go, or hiding when they have a bowel movement?
So physical, cognitive, and behavioral signs.
Yes. And success often comes when you time potty sits, maybe after meals when the gastrocolic reflex is active. The absolute rule, though, is positive reinforcement. Praise effort, celebrate successes, and never punish accidents. Punishment creates anxiety and setbacks.
Makes sense. And finally, regression. What's that about?
Regression is when a child temporarily reverts to earlier behaviors, especially during times of stress.
Like during a hospital stay or maybe when a new baby arrives?
Exactly. They might suddenly want to bottle again, start using baby talk, or lose recently acquired skills like toilet training.
What's the advice for parents then?
Generally, it's best to ignore the specific regressive behavior itself, as long as it's not harmful. Don't make a big deal out of it. Instead, focus on giving lots of positive attention and praise for their current age-appropriate skills and behaviors. Meet the underlying need for security, and usually, the regression fades as the stressor passes.
Okay, that's a lot of ground covered.
It really is. We've basically traced the toddler journey from physical milestones like the fontanel closing and gaining sphincter control right through those intense psychosocial battles for autonomy.
And importantly, linking it all back to the specific nursing interventions needed for safety, nutrition, and that positive guidance.
Yeah, if you boil it down, the clinical priorities really cluster. Safety first, always thinking about injury and poisoning prevention. Then fostering that autonomy, using those limited choices, understanding negativism, and finally promoting communication, remembering receptive language comes first, encouraging talk, reading aloud.
That's a great summary. Safety, autonomy, communication. Which leaves us with a final thought for you, our listener, to chew on.
Okay.
Given that the toddler's absolute core developmental task is achieving autonomy through exploring their world, pushing boundaries, and yet, simultaneously, this is the age they are at the absolute highest risk for accidental injury. How do we, as nurses, or how do parents, ethically balance enforcing those really strict, necessary safety limits while also promoting the self-esteem and sense of mastery that only comes from letting them explore and gain independence?
That tension right there, protection versus promotion, safety versus autonomy, that's really the heart of caring for toddlers, isn't it?
Yeah.
There's no easy answer.
Something to definitely keep thinking about. Thank you for joining us on this deep dive into the essential world of the toddler. We hope this helps you navigate this dynamic stage with more confidence,